Good afternoon, everybody. Welcome back from tea break. Let's take our seats. I'm looking for my co-chair for this session. Cynthia, where are you? Please come on up. And while we're waiting for everybody to get settled, I'll ask my good friend here, Damarius, for an energizer.
No. Hello, hello. Hello, hello. If your neighbor is not on their seat in the next 2 seconds, you are the one getting the punishment. If your neighbor is not on their seat in the next 2 seconds, you are the one getting the punishment. Everyone, picture time is over. Behind there, kindly, let's sit. So I request us to quickly stand up for a few seconds. Let's all stand up and stretch. I know we had tea, we recently had lunch, and even the digestion had not yet taken place. And we're already pumping with tea and snacks. Kindly, let's stand up. A quick one. Let's stand up, please. Let's stand up, please. Those who are on their phone, I know you're tweeting and responding to messages or getting an Uber, but we're still here. We're not going home anytime soon. So you do as I say, not as I do, okay? So this game goes like this. When I say ma, you put your hands up. And then when I say mato, you hold your shoulders. And then when I say mato, you hold your knees. Okay? So mark my words. You do as I say, not as I do. Are we okay? So mato. No, mato. So we are doing it very fast. Ma. Mato. Ma. Mato. Here is mato. This is mato. Mato is here. Then this is ma. Okay? A quick one. So ma. Anyone who has their hands down is a thief. Mato. Lupa. Mato. Do as I say, not as I do. Mato. Mato. Good job. Sit down.
Thank you so much, Damarius. So I'm really happy now for the next session. I'm not going to introduce Cynthia because she was introduced in the last session that we had, and we're running a little bit short of time. So we have our debate now, and I'll have Cynthia come up and introduce the session, as well as introduce our teams. When you're tired, you hand it over.
Okay. Hello, good afternoon to everyone. We'll be having a debate on long-acting injectable ARVs. Are too soon, too costly, and not ideal for adolescents. So we want to know from our speakers that we'll be inviting on board, if long-acting ARVs are too soon, are they too costly for adolescents? Is it, with all the investigations and all the testing, is it really necessary? And do we actually need it? So I'm going to be introducing our speakers for today, and I'll be starting with Doreen Moracha, and she says, I am a beautiful story, Kenya. Doreen Moracha is a dynamic HIV awareness advocate, proudly serves in education plus young women leadership hub, an AVAC navigator, alumni, and passionate HIV cure advocate. She recognized in the global HIV collaboration, a young leader with the International AIDS Society. Doreen co-created the digital advocacy tool, the Youth Hub from Kenya, living with HIV. She founded I Am a Beautifully Story to inspire those with HIV. Her lived experience addresses HIV and AIDS-related stigma Earning her Stigma Warrior Award in 2022, Doreen was also part of the UN Women Generation Equality Youth Task Force member, where she represented women living with HIV in the gender equality sphere. She's been amplifying crucial HIV messaging globally. In 2019, she was commended by WHO Afro, in their campaign, Tea with HIV. She received the AYP Community Advocacy Award in 2022, continuing to be a beacon against HIV and AIDS stigma. And the next I'll be calling on Bahati Haule, AVAC Tanzania. Bahati Haule is an advocate and a change maker from the United Republic of Tanzania, dedicated to bringing about equity and advancing the rights and well-being of people living with HIV, women, youth, and other marginalized community. She has served as a coordinator for Tanzania's ICU country chapter, Dignity and Well-being for Women Living with HIV in Tanzania, a CAP country representative at AfroCAP Treatment Access Partnership, and a community expert in different institutions, where she leads and supervises multiple projects aimed at empowering communities. Currently, she is an AVAC Fellow 2024-2025. She is a board and a community representative at spaces such as Tanzania AIDS Commission, Athena Network, Medicine's Patent Pool, Imprint Group, Unit 8 and Global Alliance in Ending AIDS Among Children. She believes in a future where health, gender equity, and social justice intersects to create a wall of inclusivity and empowerment. Thank you. Doc, you help me with the next. Thank you.
Thank you so much, Cynthia. So what Cynthia did was bring in our community speakers, and really she brought out the big guns. So I'm going to bring out the smaller guns. And I'm really happy to start off with calling my good friend, Professor Lloyd Mulenga. He's going to be the speaker for the proposition, and he's going to be teaming up with Doreen. I hope I do have that right. So Professor Lloyd Mulenga is an infectious disease expert physician serving as the Director of Infectious Diseases at the Ministry of Health in Zambia. He also leads the ID division of the University of Zambia School of Medicine and is accredited at the teaching hospital there. He serves on multiple boards and institutions, including the NIH, WHO, HIV drug resistance, and others. And his research focus is really on HIV and clinical outcomes, HIV drug resistance, and understanding HIV and non-communicable diseases. His profile is really, really long, so I'm going to stop there and just thank Lloyd for coming on board and being in the red corner. I'm going to say Team Red. And in the blue corner is a recent friend I've met from some of the work that we've been doing around HIV sustainability and control here in the African continent. And this is Dr. Caspian Chouraya from ECPAF. Eswatini. He's a public health specialist with extensive strategic leadership, clinical research, and technical HIV experience spanning over 18 years. In his current role as ECPAF Regional Director, he oversees programmatic and operational activities and provides strategic guidance to several countries under his portfolio. Before his current role, Dr. Caspian held various positions, including that of Country Director, Technical Director, overseeing PMTCT, Paediatric HIV, as well as services for adolescents and young people. So Dr. Caspian is teamed up with Bahati and I swept you over again. I'm sorry about that. Actually, yes, Dr. Caspian is teamed up with Doreen, the winning team, I'm told. And they are speaking against the proposition. And then Prof. Mulenga and Bahati are teamed up together. So maybe you should switch and sit together as your teams. So what we'll do is that we're going to have 7 minutes each for the lead speaker. So we'll start off with Professor Mulenga speaking for the proposition, and then this will be countered by Dr. Caspian speaking against the proposition, and then we'll have Bahati come on and then lastly by Doreen giving a rebuttal, and then we'll open it up to the, We vote now? Okay. And then I'm also being told we're going to have a voting session now before we listen to our esteemed debaters, and voting round 1. So we're using the Mentimeter. Have we had the QR code already shared with us? So there will be a QR code shared. Please scan it and then vote based on your current understanding and thoughts around this topic, whether you agree or disagree. And then we'll see whether we have a change in scores post the debate. So let's get voting. I hope it's working for you. Submit your scores. So it says, please wait, the presenter hasn't changed slides yet. So please vote, vote, vote. Can I see show of hands? Are we good? We're mostly good? Can we go on? Yes? All right. So I'm handing it over to you, Prof. Mulenga. There's a timer there that Karen is running. You have 7 minutes. And then Dr. Caspian has 7 minutes. And let's get going. Good luck.
Thank you, Zozo. And I just need to say I love young people. And I love long-acting injectable ARVs too. Am I supposed to change from here? Okay. So really, we need long-acting injectable ARVs for young people. And I've been one of the people championing availability of these drugs in our region. However, as we stand today, it's just too costly. You know, for them to be a game changer for both prevention and also for treatment, we need to be this scaled up in massive, massive numbers. Currently, the cost for Kable, I won't go into how much governments are supposed to be paying. It's just too much. Analysis done in South Africa revealed that we need at least for the cost to come to $16. But I can assure you, we are way, way, way above that. And as long as the cost remains as it is, we cannot afford those of us who are in the lower middle income countries. It has to be affordable for us to say we are ready for it. As at now, even South Africa, which is one of the countries which has resources, does not have ability to cater for its population and for the young people. And that's why I'm saying that now we are not ready because it's just too costly. And we are putting pressure on Viv, putting pressure on my friend Michael, that as long as we don't lower the cost, it's not going to be affordable for us and it's not going to be really good for our people. Another issue that we need to look at is, besides the cost, supply is also a challenge. Currently, we only have a few countries which are rolling these injectable ARVs for prevention. I'm glad that Zambia is one of the countries that is rolling out. And for this to be available and for this to have an effect, we need to have the supply broadened. We right now have just a few countries, as I mentioned. We need to have a number of these commodities available. As Zambia, for the past 2 years, we've been struggling to get cabotegravir. We had funds from the government, but we could not. I think those of my colleagues from Viv can attest to that. Only when the big guns came in, PEPFAR said, okay, we are going to buy this. I remember even what they got was not sufficient for us. It was not sufficient for the continent. When Global Fund also, I'm sure many of the countries that are going to implement this, even Global Fund, they're going to start next year in the GC7, not in this current funding cycle. So even if you have money, availability is an issue. Supply is an issue. And that's why we only have these injectable ARVs right now in a few countries. So whether you have resources, even if you're able to afford, availability is an issue. So as long as we don't address the supply, it's still going to be out of reach for our young people for the drugs which we deserve to have. So we are not ready right now, as Africa right now, as a region, because the supply is a challenge. Let me also look at the demand. You know, people say that you need to have a good product sells itself. Yes, a good product sells itself. We had a good product like COVID vaccines. Did it sell itself? No. We needed to create demand for that. Now, demand which we have has to go beyond the prevalent demand for the existing patients that we have, the existing clients that we have on PrEP. We need now to find these new other people who can receive these drugs. And we need to have this additional demand, what is called incident demand. I can give you an example. This is from Zambia. Just in the past 3 quarters, we have put 284,000 on oral PrEP. How many have we put on injectable PrEP? 1,810. And when you look at the graph below, the one with red and blue, the red are those who are already on PrEP. They are already on oral PrEP. Now they've transitioned to injectable PrEP. So as long as we are going into this same population, we are not going to raise that demand. So we need to look at the instant demand as opposed to all these people who are on prevention. That's why I'm saying that if we don't raise the demand, this will still be an issue. Young people don't want to visit hospitals. Even old people as well, like me, we don't like visiting hospitals. Only we have to visit hospitals when it's necessary. You have been calling for demedicalization of PrEP, where PrEP should be given in community settings. I have an example from my country. When we've been trying to say, where can we give these injectable ARVs? We are now giving injectable ARVs in the facilities, in the clinics. Unless we move beyond the clinics, we go to the communities, that's when most of you young people, the Gen Z, as you are saying it, are the ones who are going to have access, but it has to be outside the facilities. So this is still a challenge. But also, we need to monitor for resistance. Resistance may be an issue for those that may convert if they become positive while they are on these drugs. And we don't have capacity for resistance testing. Very few countries in our region are able to afford this. Very few countries are able to monitor. So it's up to us who are in the programming. So you young people, you need to raise the voices for us to bring demand, for us to address supply, for us to address issues of resistance, and for us to address the cost. As long as these are not addressed, we are not going to win, and we are not going to say we need it now. It's too costly, and we don't have the demand, we do not have the supply, and we don't have all these systems which are needed for us to manage this. Thank you so much, and vote wisely.
Thank you so much, Prof. I think, Dr. Caspian, the floor is yours. And he was asking whether he can take off the gloves or keep them on. I said, please keep them on.
Thank you, and good evening, ladies and gentlemen. Interesting topic. I'm going to do my level best to counter what my good learned colleague has said here. I hope the timer has not started yet. So we will be against this proposition. Myself and Doreen, I have to move this, by the way. So the first thing, one of the things that I've learned is if you are to speak to adolescents, and I think it has been said throughout this morning, you have to be adolescent friendly. Prof said he loves young people. I don't know, be the judge. I'll show you some information. So this is me. I have adolescent children, a 14 and a 16-year-old. We have taught me quite a lot about what it means to be an adolescent. I work for a pediatric and adolescent organization. Adolescent is in the name of the organization that I work for. Vote wisely, please, as you look at all this. I went to ResearchGate. I looked at the articles that I've published. 66% of them are on children and adolescents. Again, be the judge. I won't tell you what it means. I looked at my good friend here. I couldn't find anything about him on family, unfortunately. His social media is just as blank as mine. However, he works for the University of Zambia Medical School, and he deals with students. I looked for the article published by a Zambian, and the median age of university students at the medical school in Zambia is 22 years. So you can see the reference there. So again, be the judge. Is he really adolescent friendly? I went to his ResearchGate page. This guy is published. He has close to hundreds of articles, but only 7.6 of his articles are actually on pediatrics and adolescents. Again, be the judge. I won't say more further than that. So let's get to the issue, right? Why adolescents? I'm not going to dwell much on this. I think a number of people, Dr. Nyaradzo and Ngosa, talked about a number of things this morning about why we really have to prioritize adolescents. The main thing I just want to let you know is mortality within our adolescents living with HIV continues to be very high. All other populations, we are seeing a dramatic reduction in mortality, but for adolescents, that is not the case. So the question is it too soon? Do we wait when our adolescents are dying? We have this goal of ending AIDS by 2030. But if you look at the data that we have right now, adolescents are lagging behind. If you look at the progress towards the 95, all ages, we are getting there. 93% of adults that are taking their ART are virally suppressed. But if we look at adolescents, only about 55% of them are suppressed. So again, should we wait when these adolescents are dying? And we know for sure that long-acting ART is going to work. It actually works. We have data, we have studies that have shown that a replication is actually reduced when adolescents are taking a long-acting ART versus orals. So we do have data from the recently ended CROI in March of 24. So we do have the tool. The issue is adolescents are not taking their medication as they are supposed to do. The oral that we are currently are talking about, my good professor here was talking about resistance. It's already there. They are not taking their orals. They are resisting. So the issue of whether we have to test or not is already happening right now. But we have a tool that might be potentially a game changer. So the issue is, why wait? When you can actually do something for these children, the time, ladies and gentlemen, is now. Is it costly? I agree with my good professor. Yes, I know long-acting ARTs are very, very expensive for now. However, we do know that they are going to reduce mortality for our adolescents, which, as we all agree, is a big issue. And like he rightly said, we already know the threshold of where these long-acting antiretroviral drugs are supposed to be for them to be cost-effective. At the current price, I agree, I admit, it's not cost-effective, but we have the data on where we are supposed to get them to. So the question is, do we just again fold our hands and wait for prices to go down? I say no. We can start now. We can do something, and these are some of the things we can do. We can prioritize who gets these long-acting ARVs instead of giving everyone in terms of our adolescents. There are those that are struggling. There are those that are really not adhering quite well. And we know we can always negotiate for prices. What we are talking about right now, the driver of this high cost is because most of them are brand names. If we go for generics, we know the costs are going to go down. And we've seen this over and over again. I'm just giving you examples of drugs that have gone down. It starts very high and then it goes down. So the question is, do we wait or do we start now? So yes, cost is high, but I think there's something we can do even right now. Not ideal. Again, I've gone through a number of studies, searched quite widely from the US. Adolescents themselves agree this is the way to go. Give us a long-acting injectable ARVs. 88% in the US. In South Africa, they also agree. High acceptability. This is ideal for us. I can't spend all the time taking drugs when I could be partying and doing all these things that Damaris was making us do and all the others, earlier on. So I can't be taking daily when I can just get this once a month. So they're acceptable. Uganda, same thing. 94% of the adolescents are like, yes, this is ideal for us. This is what we want. This is going to work for us. In Kenya, same thing. So from all the research that has been done, this is acceptable. This is what the adolescents are actually talking about. I know there are barriers, like my professor has already said. One of them, like I indicated, he was going to say, I knew he was going to talk about cost. Like I told you, we can do something about it. The issues around cold chain, we can do something about it. So all the barriers that might be there, and these have been identified from the studies: physical space limitation, fear of side effects. I mean, every drug has a side effect, and we can do something even about the long-acting injectable. So all these barriers are not insurmountable. They can actually be fully addressed. Lastly, we also at the Elizabeth Glaser Paediatric AIDS Foundation work with a youth group. It's called KAYA, Committee of African Youth Advisors. These are youths, adolescents that are placed in different countries, that we work because we're a pediatric and adolescent organization. We have to be advised by them. Again, as we were saying, nothing for us without us. And we talked to them about the same question as well. I'm not going to read all this, but you can read at your own time. Trust me when I say all of them unanimously from the different countries where we ask them, they're like, this is what we would want to. Taking pills daily is somewhat a huge burden for us. We feel we should be doing getting long-acting injectables. So this is where I end, and thank you very much. I don't know if I pass it to my good friend or it's going to come to this side.
I think I'll let Cynthia introduce her good friends, and maybe we ask them to keep the gloves on because looks like Caspian took his gloves off.
Okay, thank you very much. It was a hit. Now I'm going to be introducing the next speaker. We're going to be having Bahati, and Bahati will be coming as the proposition for the fact that long-acting injectable ARVs are too soon and too costly. So let's go.
Good evening, everyone. I hope you all are having a wonderful time with our debate. And I won't be having slides because I want you to lend me your ears and your attention. I've seen Dr. Caspian has decided to go low on my dear good professor. And he is talking about an ideal world where we think what we want. And we are not living in an ideal world. We are living in reality. We might wish as much as we want, we might say as much we want, but what does that reflect in our resources and the situation in our country? So he says, trust me, we can, but that's not the situation. And as the motion says, long-acting injectable ARVs are too soon, too costly, and not ideal for adolescents. And in good faith that English is both not of our first language for him and I, we are not saying we brush off forever long-acting. We are saying currently, in this day and age, ARV are too soon, they are too costly, and they are not ideal for adolescents. And knowing me and my colleague, we have been given 4 minutes. I'm going to add on to the points that my dear good professor had started stating on why we believe that currently ARVs are too costly, too soon, and not ideal for adolescents. I'm going to speak, first of all, to alert you that when we do talk about long-acting injectables, let's not think only about prevention. We are talking also in terms of treatment. So in an essence of not leaving anyone behind, we are going to discuss of what is there for treatment and prevention in the essence of long-acting injectable ARVs. So currently, as it was stated, and it is known that we do have complexities in the supply chain and storage issues when we talk specifically for the long-acting injectables that require cold storage. And I'm coming in an angle of treatment where we know is, as Dr. Caspian was saying, we believe we can, but that's not happening currently. And ideally, in a realistic world, we'd wish that we could be able to do that, but that's not what is happening. And we know we have challenges in our current healthcare system in our own countries in low and middle income, particularly if we think about rural and low resource areas to deliver this medication reliably and every day to ensure that these adolescents that we want them to transition, how can we promise and sustain them that once we start supplying them with the long-acting, we'll be able to ensure they are on this treatment beyond just 2030. And there, as Ishu said, there are potentials of resistance. It is known, especially for those young people that are currently on the drug resistance on prevention. We know once they do acquire HIV, it's very difficult to revert them back on the same class of medication. So this risk really emphasizes on the importance of ensuring that all individuals, without leaving anyone behind, especially the young person, have access to comprehensive education, which is what we should be targeting now as the gaps in our society, so that when the time is ideal and we have the long-acting injectable prevention and treatment option, we know that we can ensure this won't be an issue. But we know also in our society we have issues on access and equity issues. We understand the complexities that are there in administering long-acting injectables. It requires really systems and structures of our healthcare that is really strengthened and available in all regions, meaning both urban and rural settings, which is not currently there. And as I said, in an essence of not leaving anyone behind, we should also consider adolescents who are living in rural and underserved communities and those of key population that are still facing stigma and challenges, and they may face still significant barriers to accessing these long-acting injectable treatments. But also there are issues on if we compare the clinical effectiveness of the long-acting injectables to the oral regimes. We understand that current studies shows that injectable therapies do not offer superior efficacy compared to the existing oral regimes that we have. And this is across all populations. So if the clinical benefits do not really justify these high costs that we want to impose on ourselves, and also the logistical challenges that are there that are associated with the injectables, it raises really the question of if it's really ideal currently where we are and the state that the gaps that we are facing. Is it where we want to put our money and resources? And we understand the challenges as we have been speaking since morning to now. So I believe long-acting injectables, yes, they are innovative options for both treatment and prevention, but there are a number of issues: the cost, the potential for resistance, the development consideration for adolescents, and access disparities. All of this suggests that we are currently at a premature and not at an ideal stage for us as a demographic to roll out this STEM in our communities. Thank you.
Okay, thank you very much, Bahati. I'm sure by now we should be asking ourselves, did I do the right choice in choosing, in voting previously? So let's get on to hear what Doreen has for us. Thank you.
Good evening from the winning team. So, this is me when I stopped taking ARVs. Why? Because I wanted a drug holiday. I was tired of taking ARVs. And this was just 6 years in. And I've been on ARVs for 19 years. So it is not too soon. In fact, it is too late. We need long-acting now. This was me at 8 years old when I was officially diagnosed with HIV. ARVs were too costly then, and there was no reassurance of a quality of life. If I had started ARVs then, we'd have saved a lot of money from the various opportunistic infections and hospitalizations. Besides, now we are living in the era of U equals U. That means investing in ARVs ensures a healthier, more productive populations. Besides, the good doctor already said that we can always negotiate on the cost, okay? So definitely cost can be worked. So, on to my last slide. I asked the people, apart from me, what do you think about the the long-acting. They said they will help boost confidence. They said they will make it easier for people who struggle taking it daily. When we are going to Anguka Nayo, we are not Angukaring with our ARVs, okay? They said it will allow individuals who are HIV positive to accept their status and to remain faithful to their ARVs. So as we are voting, remember, it is not too soon. It is in fact too late. It is not too costly. We can work on that. And it is very ideal for adolescents. Thank you. Vote wisely.
It seems like we have politicians here threatening us to vote wisely. Before they congratulate each other, I think we should ask for Kitenges, some Millimil to help us vote. So ask Prof. Mulenga to come back with a rebuttal, 1 minute rebuttal, and then ask Dr. Caspian as well, come back with a rebuttal, 1 minute rebuttal, and then bribe us so we can vote wisely.
Thank you, colleagues. I have a very good track record of bringing drugs in the resource-limited settings and fighting for those drugs from WHO, fighting for those countries at country level, and I fight for long-acting ARVs as well. That's why Zambia is one of the few countries that have brought it. But we have to be real. They are not as cheap as my friend is saying. The negotiations are very tough. But also, to bring this, we need numbers. The demand is not there. Supply is not there. We have to be realistic. As long as we don't address those, we are not ready for now. My good friend says viral suppression. We have drugs that are doing viral suppression. Let's concentrate on what we have as we are advocating for bringing in these good medicines. Let's also look at improving the systems. We want drugs to be available near where you stay, young people. And here, let's be real. I have a track record of bringing things in the countries. I have a track record of dealing with the young people. Not just speaking. Speaking is easy, but bringing those, it's a different battle. Thank you.
This is going to be a tough one, honestly. I'll start with this quote. I'll read it verbatim from Malcolm Ben. It says, "If you wait until you can do everything for everybody, instead of something for somebody, you'll end up not doing anything for anybody." This, for me, summarizes everything. Our adolescents are dying, good people. The drugs work. I'm not saying they don't suppress. They work, but they are not taking them because they have to take them daily. We are saying here is a solution that can allow them to make sure that they take the drugs. The orals work if they are taken, but they are not taking them, so there's not going to be any viral suppression. So we have to make sure that we have a solution which allows our adolescents to take the drugs. We've shown you the data. They are dying now, not tomorrow. They are dying now as we speak. More than what is happening with adults, even more than what is happening with children. We have to act, and we have to do it now. We can't wait any longer. Cost. Like we said, I mean, no one lives in an ideal world. Like I said, we don't have to wait until things become ideal, my good sister. Until we can then say, oh, let's now bring long-acting. We start from where we are. We do something for somebody. In that way, we'll be able to change the status quo. So, ladies and gentlemen, I think this, for me, should be a no-brainer. The time is now. Adolescents are dying. Money is just money. We can negotiate. We can talk. Yes, it will be difficult, but it can be done. Yes, we can. I end it there.
I don't know whether Bahati and Doreen, you have a 30-second rebuttal, or you leave the professors. Okay, all right, that was a really good debate. I'm not sure which way I'm voting, whether to vote for my country or to vote for logic. But vote we must. So again, we'll scan, right? Mentimeter will come on and cast your vote. Those that received bribes before the debate, honor your, your paymasters. All right, let's get voting. The internet, there's some, somebody's doing some tricks in the background. It's been rigged. The Electoral Commission has been tampered with. Let's get voting. I hope you voted for yourselves. Oh. All right, can we start to see the results? Round 2, first round 1. So for round 1, we had 20 people agreeing with the statement, 16 undecided, and 76 who disagreed, or 78. Okay, so let's see what we did with round 2. Round 2, I know it was an uphill battle for Prof and Bahati. So round 2, 88 disagreed with the statement and 16 agreed with just 1 undecided. We're going up to 90 now, but really it was an uphill battle for Prof. Mulenga and Bahati, so I really thank you for your livened and passionate arguments. I know where your heart lies, and if you're voting, you must have been also voting on the other side. And to Caspian and Doreen, thank you so much for moving the undecided to the decided, and some of those that agreed over to the other side. Ladies and gentlemen, I think we're at the end of this, and today's session is coming to an end and closing, but there's some housekeeping matters that I have to go through. So we have a group picture that's coming up now, and oh, we didn't allow for question and answer from the team, but hey, yeah, sorry about that, but it's okay. So we'll go for group picture, and then we have the networking reception. Please do stay on for the group picture. We have ushers that will guide us to where we're going, and then we have a reception afterwards, and I hope you all be able to stay on for the reception. Thank you so much for engaging today, and see you tomorrow at 8:30, I believe. Yeah. Thank you.